Wang. I'm from the United States, and I will be our chairperson, and I would be very happy to introduce our moderator today. He is the president of the European Rhinologic Society. Dr. Terzis will be leading our discussion on the frontal sinus surgery, so very excited to have this wonderful opportunity to hear him and our amazing team of panelists. So with that, I will introduce Dr. Terzis and let him start us off.
So good afternoon. I'm sorry I missed the American flag from the first slide. I didn't know of the change of the president. So, thank you. So we'll discuss a few cases which I think cover a range of diseases and conditions in the frontal sinus. So we start straight away with the first case, young man, 23, with a mild perennial nasal obstruction, more on right. He actually presented because he had a recent episode of severe right-sided frontal pain while diving, which he had in the past 2 more times. He's had several courses of intranasal steroids with no change, and he asked for help. On clinical examination, the septum was deviated to the right. And this is his CT scan, and you can see, let me see if I can show you with the pointer here. Yes? You can see the pointer? No, you can't. Anyway, so we can see there's a diffuse mucosal thickening in most sinuses. You can see the septal deviation, especially on the, I may be able to show you here. So you can see the septal deviation here and there, maybe a bit more prominent. You can see this diffuse mucosal thickening with the partial obstruction of the ostia of the maxillary sinuses. And we have some anatomy in the frontal recess, both sides. This is the right side, and we have this agonizing cell, which you see. This is a free-plane reconstruction, obviously. So we see a large agonizing on the right side, obstructing the frontal sinus drainage pathway, and you can see this thickening just over it. And on the other side, we have, again, the agonazi and a type 2 supra-aga cells, anterior cells, just over it. And this is the cross on the left side, and you see the more complex anatomy on this side. So that's the summary, right? Septal deviation, mild mucosal thickening in most sinuses, partial obstruction of maxillary sinuses, frontal anatomy, as I said just before. So how would you treat these patients? Intranasal steroids, surgery? What sort of surgery? Could a balloon would be a case in this? So, Andreas, would you like to comment first, please?
It's a nice case. I would like to know about the CT scan. How old are the scans? Are there more than one scan available? So, do you have maybe an MRI as well?
Sorry. That's the pictures I have here. And we have this film here of the coronal. Maybe you can see a bit more.
No, they are nice. I mean, the demonstration is great. But that's the only one. And it's an actual CT scan, so it's not an old one. Okay. Are there any comorbidities? I mean,
no.
Asthma?
Otherwise healthy. 23-year-old
Okay.
young man.
So your question focus purely on how to manage now this problem.
Yes. Would you do surgery? What kind of surgery?
I mean,
He's had several courses of intranasal steroids
Yes.
already with no...
I review this patient 2 or 3 times to get more feeling about how they respond for conservative treatment. I do it really aggressively for a bit more time because there's no emergency. And I would like to know about the intensity of the symptoms. So ask about visual analog scale, if it's 0, 1, 2, 3, up to 10. 10 is maximum. So this gives me a little bit more feeling about what's going on. And if I know the patient and it's not just one C and one indication going for surgery, then I would say, well, there's an option for you to open this, space up into the frontal. And there's as well this septal spur. And maybe the septal spur is affecting and creating the pain as well, a contact headache point, maybe. So these are the options. So balloon in my hands, I wouldn't go for it because it's very complicated to go up and maybe to create more problem than benefit. And in case of surgery, I would do what I'm presenting here, the School of Graz. I would follow the anatomy and going up very gently.
Absolutely.
And that would be my option.
Right, thanks very much. Phillipe, would you like to comment, please?
Well, I think that in this case, I would like to know if the headache were on the right side or on the left side?
Right side.
Yeah.
The right side.
The septal spur.
So we see that there is a diffuse hypertrophy of the mucosa within the sinus, but we want to know how long does it take for a flu, for example? How long does this patient has secretion, postpurine secretion? Because sometimes it's very short and sometimes it lasts for at least 3 weeks. So if there is long infection, then of course there is a sinusitis. The problem is that he already tried intranasal steroids with more or less good effect. And so probably I would like to do the surgery, as Andreas said, septoplasty and very delicate surgery of the ethmoid without resection of the mucosa.
Yeah. Tim, just a comment. I would maybe go for maybe endoscopic septoplasty, doing, just a little bit, a little incision, and going for this. It depends how does it look like when you make endoscopy.
Well, the extension of the spur is quite large, actually. It's not just a little spur. The length
it's
of
not
the
a problem.
deviation is quite
You
large.
can do it very nicely endoscopically.
Yeah, sure.
Anyway, may I remind you that the patient came to me because of the barotrauma, sinus barotrauma he's had for the 3rd time. This was the main reason he came to the clinic. And of course, he had some mild nasal obstruction, which was treated with intranasal steroids before that. But the main reason he came to me was the barotrauma or barotrauma-like pain in the frontal area. Wytske would like to comment, please?
Yes, well, I would like to hear exactly that. How long does the pain last after the dive? Apparently he went diving again, so it wasn't a VAS 10. I had a few barotraumas in my life, and I assure you that you're not going to dive the day after. It's really painful. So, and then there is, of course, the question, why does he have the pain on the right side? You don't get a barotrauma of that spur, so I see no indication at all to remove the spur apart from the minor nasal obstruction that he has, or that I can't reach that cell. But why does he only have pain on the right side? Because the most of the pathology is on the left side. And also I would like to know how long this CT was after his last diving. Because if you really had a barotrauma, you have more disease afterwards than this.
The CT was done about 2 weeks after the episode.
2 weeks after a barotrauma, you expect more disease than this. So that is a combination of, so then I would ask him, did you have a cold with the same sort of symptoms? To get a little bit more feeling whether the the pain actually came from that frontal sinus.
Right.
I'm not convinced.
Maybe you ask the neurologist, I mean, you know, just to sort out if there's a different kind of pain. But once again, headache point is a topic, and I have quite, not many, but I have patients, and in case there's a contact between septum and the lateral nasal wall or middle turbinate, there can be, and this is the differential diagnosis.
barotrauma?
Sorry?
Give a barotrauma?
No, I'm not talking about the barotrauma.
Well, that's the only moment
but
he has pain.
I'm just talking
No,
about the pain.
Yes, I said barotrauma-like headache. I mean, I don't really believe it's a real barotrauma, but maybe a dysfunctioning outflow of the frontal, both sides, because of the anatomy, plus the chronic rhinitis. This is my concept of the thing. Yes, Phillipe?
Just one comment. We know that chronic rhinosinusitis are influenced by the environment. And so diving can generate, of course, headache and something, but if you do a surgery, and if your surgery is not adequate, completely, if you do not have a very clear anatomic pathway, you may have headache due to your surgery. So if you do the surgery in such a case, you must know perfectly well the anatomy and the technique to open the anterior ethmoid and the frontal.
Right. Jannis?
I also think this is not a classical CT for a barotrauma 2 weeks after.
Absolutely, I agree.
And if there is no history before, if the patient has no problems before, I will wait, not operate. I will clean the nose with saline solutions, with local corticosteroids. I will follow the patient, and exactly if there is, what Phillipe said, if there is an indication in the future, if there will be an indication, then I will do a complete ethmoidectomy, removal of this aganasi cell, of the suprabular frontal cell, so a type 2A or B. I think A, it's enough in this case, but it depends of the anatomy with the curved curate to remove these cells, and if we decide to do it, but no surgery in the beginning.
Okay, Vlad?
Yes. I totally agree with my colleagues here. The only thing I saw on the sagittal CT, that is a very well pneumatized frontal sinus on the right side. And maybe it's like a mechanism of pneumosinus there because of that agar-nazi cell. This will be the only indication for the moment to remove that agar-nazi cell. Otherwise, treatment will be very good.
Now, because I worked for many years for the Greek Navy, we saw people, divers of the Navy, having headaches frequently after diving. And if we saw this sort of complex anatomy in the frontal recess, plus some mucosal thickening there, we used to operate on them, and the problem was relieved. So in this case, we did a draft 2A. This is the left side, the end of the operation, obviously. This is the left side, and you see wide opening into the frontal sinus. And this is the right side. Also, you can see a wide opening into the sinus. So we move to the second case. 60-year-old ex-boxer, left frontal headache.
Tim, can we ask you something?
Yes.
I hear it zooming around me, so it's better to ask you. How long did you follow up? Because I know a famous UK professor who said, after the surgery, they give you a present. After a year, they want it back. if you talk about sinus surgery for facial pain and headache. So how long did you follow up this man for?
This was a recent case, actually.
Okay.
So, and he doesn't live in Athens. He had to move to London where he studies. So I'll tell you next at the next conference. So this is a case of 60-year-old ex-boxer who came with left frontal headache he had for 6 months, mild obstruction, otherwise good health. The only significant thing in history, 35 years ago, severe injury to the eye and the maxilla with a fracture, septal deviation to the left with edematous mucosa, and I couldn't identify the left middle turbinate. And I could see this septal body on the left side, white swollen. And that's the CT scan. So we see the left frontal sinus is obstructed, and we can see the septal body here, quite swollen, no middle turbinate identified on this slide. This is the frontal recess with an aganasi, and what is this? I mean, we can see this alteration of the anatomy of the orbit here, and we can see that the ethmoids, especially the anterior ethmoids, are obliterated by this fracture of the lamina papyracea. So if somebody tries to get into this ethmoid, it's quite dangerous because he may enter the orbit here. So how would you comment this? Wytske?
Well, you obviously see that something seriously happened 35 years ago, and or part of the orbital content, mostly fat, but also, well, almost the medial rectal muscle, is sort of pushed in the ethmoid. But you can also nicely see on the lower sagittal plane that there is quite a lot of space to go through that aganasi cell upwards into the frontal sinus. I would be really interested in a case like this to understand how this problem started. Because for me, a very important question on what to choose, it's obvious that he needs surgery, I think. But then the next question is which surgery? And I would be very interested to know what the cause of this problem was, because you see the rest of the mucosa is absolutely impeccable. There's absolutely no sign of other swelling in the sinuses. So I would be quite comfortable to would discuss with the patient to take the risk and try to very gently, like Andreas described, go through that aganasi and move up there. I think I would be able to make enough space there to get rid of the problem. But there is, of course, always a chance that as that mucosa is very inflamed, that you can't keep it open long enough to let that heal. So that's the discussion you have to do with the patient. And the next step, well, is at least a 2B, but there's not much space to gain. So then I would go for a draft 3. So that is but if I would advise the patient, I would say, you know, we can do a very tiny, gentle surgery and try to get that root, and the chance that it stays open is significantly, but we can't promise. Okay. And if you absolutely want to be sure that it remains open forever, we have to do a draft 3.
Okay, Andreas wanted to say something?
That's a very good plan by Wytske. So I would be interested, I mean, the case is fantastic because it's a bit away from a standard case, so a little bit more tricky. And the danger is really the medial orbital wall, which is protruding. It's looking like somebody who came to the Oktoberfest, had too much beer and got some in the face. And we had these patients, and we have to tell the young colleagues that they have to be aware and not going in this, structure, because you can grab the rectus medial mass, and these are the worst complications you can create, even more worse than a CSF leak. But I had patients with a single frontal sinus opacification which responded not to bad, not every, but some, to more aggressive conservative treatment. And the question is, I mean, how long did you treat this patient? Did you treat him for a couple of weeks, 4 weeks, even longer? I had patients, I did it with macrolides. I mean, yes, I mean, we can discuss it with steroids, and it went fine, some not. And I think Wytske will agree that she would go in the same way, and then if it's not responding, of course, do a type 2A first line, and if you see it's not working, yes, you can do a type 3, but I think it's working. When do it gently, yeah, it's working.
Well, the problem with draft 2A is that you must leave a space wide enough to be sure that it will not be closed post-operatively.
Or you adapt it to a 2B, or, I mean, you can individualize it during the surgery. I cannot tell you how does it look like when I'm in and looking with my 45-degree endoscope up. So it depends, and that's the message. You have to adapt a little bit, yeah, and play a little bit around.
I agree to that. Vlad?
Yes, from my point of view, surgery is necessary at this moment, but I think a draft 2A will be more than enough because we all don't want to have any complications and the risks are very bad. So my strategy here is to just open and make the air go into the frontal sinus, wait to see what's happening, then a very aggressive treatment, also just after the operation, and then I think this case will go right.
Okay, Jannis?
I think in this case we need an incrementally approach, and the decision will be made intraoperatively. So I will start to drainage the frontal sinus, because this is a classical post-traumatic chronic frontal sinusitis, because you see also neosteogenesis, you see that in the bone the bone is also active, and this is something that shows us that this is a long-term infection there.
Yes, and of course he had the symptoms for at least 6 months.
Yes, and I will try to do a type 2B, because I see over the septum to the other side, I see also a connection to the other side. So I think I will try to perform a type 2B, but the final decision will be made intraoperatively.
Okay, Phillipe?
For this case, I want to scan at least 3 months of distance. The second is that when you do the surgery, I can compare it with the orbital decompression in Graves' disease. You have, of course, bulging of the orbital contents within the ethmoid, but there is a fibrotic web. You do not see directly the fat, and if you do a gentle surgery, you can visualize the fibrotic web. You do not penetrate, so that's an important point. The second is that I prefer to do a draft 2B in this case, because there is no more middle turbinate, and of course there is maybe an opacification of the intersinus cell, so I have to do it. And maybe one comment, maybe from France, there is a trend to do in such a case of unilateral frontal sinusitis with difficult anatomy to perform a septectomy, just to resect the septum between the two frontal sinus, and the drainage will do through the other side, the opposite side.
Okay. So we did the draft 2B in this case. Yeah. I selected the anterior approach, and you can see the opening into the frontal sinus and a little opening in the intersinus septum to the other side, just to make sure that if it closes, we have an alternative drainage to the other frontal sinus. So that's what I decided to do, and this is post-operative condition of the 2B. 1 month, 1 year, and 3 years post-operatively, the opening is wide open. Yes, Andreas?
Tim, just a comment. I mean, we should appreciate the literature, and when we talk about draft type 2B, we have now the IFAC and EVES paper, which was published by P.G. Wollmer and the group, and they differentiate a little bit more how they go into the frontal sinus. So you have a grading, grade 4, grade 5. So this prescribes a little bit more and more precise how we access the frontal sinus. So I agree, drill out, makes sense. It depends how much you remove, and then you have your grading. And this has to be documented. And I think it's of high value to speak with one language when we do surgery.
Okay. So here comes the discussion about draft 2B. A few years ago, I was at David Kennedy's course in Pennsylvania, and I heard Wolfgang Draft saying that draft 2B is the least successful of all draft procedures. And indeed, the reported or initially reported closure rates are higher, as you see in this approach. But then we have this paper from Stanford, which actually found lower morbidity in 2B and similar results between draft 3 and 2B. And this is an older paper, number 4, from Adelaide group, stating the prediction markers of stenosis, small ostium, and severe disease. So, generally speaking, do you favor 2B or you go straight to draft 3? Wytske?
It totally depends on what the disease is. Well, first to comment on that IFAR paper, I don't think the numbers in that paper are large enough to say that one is that they're equally good. You just can't say from a statistical point of view. But for me personally, much more important is what is the underlying disease. If there is a mucosal problem and there is lots of swelling of the mucosa, and I can't get that mucosal component under control, often the reason to do the surgery, then I would never choose a 2B, because I learned exactly that from Wolfgang, and I still believe he's right. If, for example, there is an inverted papilloma in the frontal sinus, and you have excellent mucosa, and you know it will heal beautifully, then a 2B is a great possibility, because Absolutely. It will. So my decision is not only the anatomy, or mostly not the anatomy, but much more the state of the mucosa.
Totally agree. Anybody else wants to comment? Yes, Phillipe?
I think that when we do a draft 2B, we must drill a lot.
Yes.
And at the beginning, we think that, well, the opening is okay, well, it will cure. No, you have to drill a lot, and you must remind that when you think that it's enough, the procedure starts. That's a very important thing.
Yes, good point.
Tim, may I ask a question as well? So when you expose that much bone using a drill, does anyone use any adjuncts to help that heal, like free grafts, free mucosal grafts? Or did anyone use stents, anything of that?
I think this is a very good question, and I think this is pointing out the problem. So it makes a difference how we do also the draft 3 procedure. I work with Wolfgang, I know how to do it, but the problem always is how to protect the mucosa in the lateral aspect of our drainage, in the posterior aspect, okay? And so, I'm coming back to Wytske, the pathology. If the patient has multiple predisposing factors, multiple allergies, asthma, Samter trias, you have not a good mucosa in all your drainage, so you cannot make flaps. What I do is routinely, if I perform a type 3, is to try to preserve the mucosa in the lateral aspect, to take the mucosa from the middle turbinate axilla and to rotate it to the lateral aspect, or to protect also the mucosa on the perpendicular plate and to rotate this mucosa on the posterior wall. But the question is, what Wytske said, What is the reason? What is the pathology? And then we can discuss about which is better, type 2B or type 3.
Right. Yes, Andrea?
I think the type 2B is indeed the approach having most risk to restenosis. However, it depends what Wytske said, pathology, and on your local anatomy. So you go up and you will see how you can open it. And as long as you denudate very much bone, a large area, and it's narrow, I think it will shrink a lot. Maybe you can use some local pedicled flaps. I don't have really experience. I know colleagues, they say it's working not too bad. I have some experience in using stents, more in taking out, but you know, when I'm talking about stents, I talk about the drug-eluting stents, but I stopped using it for denudated bone because the wound healing is affected, so you have more granulation, you have more maybe super infection, I have fungus seen on these, so I wouldn't recommend, but I'm talking about a series of 50 cases and it's just, you know, my opinion. But
right.
You are asking the
Mine. Yes,
Just a short comment. Oh, sorry, Phillipe. Oh, okay, just a short comment. I'm looking in this kind of cases not only at the mucosa, but also at the bone. If we have new osteogenesis, this will let me decide exactly if to make a 2B or a 3 one. 3
Okay.
type.
I think when we think about surgery, we must be very conservative. And of course, a draft 3 can be the option. But I have some feelings just to touch a normal frontal sinus on the opposite side when there is only disease on one side. So for the majority of the case, I tried, except in CV mucosal disease, I tried to do the draft 2B before doing the draft 3 in unilateral frontal sinusitis.
Sorry, Andrea, we're quite back in time, so...
No,
yes,
I think it's
okay.
important, but that's a really important question. So there's a very good paper by Anderson from New York, and he classified the way how you can approach not draft type 1 to B, 2A to B, 3. He differentiated more, and I think that's exactly what I do. I play around, and it depends on your local anatomy, once again, and how you can approach disease as well. And when you this keep in mind, I think you can be more successful.
Yeah, absolutely. So, case 3, 51-year-old male. In the past, he had an operation for septoplasty in a way, followed by intranasal steroids. And 6 years later, he came back with some mild frontal headache, more on the right side, which was okay with analgesics. And we did the CT scan, and we saw this little osteoma here, which was quite small, as you see, originating from the posterior wall and just touching the anterior wall. Four months later, analgesics and anti-inflammatory drugs, not enough for the pain. Patient was in real pain. So I insisted that this pain, it was quite unlikely that it is caused by the very small osteoma. And I sent him to the neurologist who gave him antidepressants and drugs for chronic pain and so on. No effect. So the patient came back after a few months in severe pain, insisting I do something for him. So what would you think of this, Jannis?
This is a difficult question. I will follow the patient. If the headache persists and continues, then I will talk with the patient that I will try to remove this osteoma. I can't believe that this is the reason for the headache, to be honest.
Okay. And another thing is, the osteoma is on the left side and the pain is on the right side.
Yes, that is something that is strange. But if we have checked our patients neurologically and if we have done everything, then the only solution is to remove it, but I will not go for a surgery, to be honest.
Andreas?
A good case. Because start first thinking and then operating, or maybe not. I mean, do you have more scans? I would see the anterior ethmoid cavity a bit more, because I have cases with an osteoma like this, and the problem was not the osteoma itself, it was more, you know, in the anterior ethmoid cavity, maybe. And is this the only scan you have? Do you have more? Do you have...
Yes, sorry, I haven't got here more than this.
Okay, and it's looking always the same. It's looking always the same.
Sorry?
It's looking like this CT scan. There's no
absolutely.
pathology, nothing. So having
Nothing
the pain
more.
on the other side
Exactly
and having...
what you see. Just a little osteoma, no disease in the nose, nothing.
I would be very conservative in this case, so that's
Wytske?
high.
Well, you know, I assure you, this is after the surgery he gives you a present, after a year he wants it back, and in 3 years later he will sue you for giving him a headache. So, no surgery on a case like this.
And Tim, talking about surgery here, I mean, it's not easy. It's not easy. It's very high up, and the diameter, even when you do a type 3 or you take the internal beak, it's hard, and you get it away from the pedicle, but then you cannot grab it because the diameter is too deep. It's not easy.
Yes, Phillipe?
So I think that an osteoma gives symptoms when there is impact on the frontal sinus itself. It's, in this case, the mucosa is quite normal. The pathway is completely normal. So for me, there is no indication just to do surgery, even if the patient insists for this. Okay. We know that headaches has a lot of favorizing factors. And so for this, we have to send to the neurologist or something, but there is no... The other thing maybe for interesting people, that's when you do a middle antrostomy, you must include the main osteum, and recycling is very common. And so when you look to the CT, something you see that there is a wide opening in maxillary sinus, there is persistent of insidates, and you may have recycling. We must think about this because he had middle antrostomy before.
And you can...
Vlad, you would, sorry, Jannis, you want to say something?
You can, what I sometimes do is that, I'm sorry, to applicate local anesthesia in this area and to see what happens. This is sometimes very helpful. I do it also if I have a neuralgia of the superior laryngeal nerve, and this is really helpful to make a differential diagnosis, what happens.
Okay, Vlad?
For sure, my opinion is not to operate on this case, but I'll do a more intensive discussion with the patient to see exactly if he has a severe pain, or maybe his problem is that he has a tumor in his head. So if you can differentiate about these two things, just talking to the patient, maybe you'll get a better result than the operation.
Well, actually, as you see in the history here, I agree with you. I mean, I didn't want to do surgery because I thought that pain had nothing to do with the osteoma. Yeah. But then I thought again, and I said, I have a patient in real pain, going from doctor to doctor, consuming all possible medicines for that with no result at all. And actually the pain was getting worse and worse. And I decided to operate. So I did a draft 2C, which is an extended draft 2B.
But Tim, how can you explain the pain on the other side? I mean,
sorry?
The pain on the other side, on the left side, and the findings on the right side. So this is...
Yes, but sometimes you get reflections of the pain in strange areas, to my humble experience.
But the osteoma doesn't give severe pain anyway.
Yes, I agree.
Never.
Totally. I totally agree. So the osteoma was removed with an extended 2B or 2C, and immediately postoperatively pain disappeared.
How long?
Quite long, actually. 4 years now. Okay. So a few words on draft 2C, which is an incomplete draft 3, basically. So we do a draft to be on one side, and we just go to the other side, crossing the midline, which could be a stage of draft 3, as we do sometimes. And it can help in some cases. You want to comment on that? Draft 2C?
Well, I really want to comment on the case, Tim. I think for the audience it's extremely important to understand that this is something you should not do. Because you were the lucky guy that came out of this case without having been sued or having another serious problem. But we all have experienced that if you operate on this sort of patients, that either it closes off, and you were the one who did the surgery, or the pain comes back, and you make a complication, and if you're in court and you see this case, and you made a complication, you're sued. So I think we should make a clear message as a group that this is a wrong indication and we shouldn't do it.
Okay. Andreas, you wanted to say something?
I mean, yes, Wytske is right. I mean, I would be very carefully, I would be more conservative. I mean, the arguments are right. I mean, we have to give one message to the audience, and I think this has to be discussed with the most experienced one in your field, and even he has to be thinking very hard. I mean, Wang, what do you do there?
What I would say is that this is where building multidisciplinary teams to help you is critical. I have 2 or 3 neurologists who actually are passionate about headache, who have helped me incredibly with these kinds of difficult cases where there's a little something, maybe even just the mildest amount of inflammatory disease in that frontal, but you and I are both fairly convinced that, if we operate on this, it's just going to cause us pain. You know the old saying, if you operate on pain, it just causes the surgeon pain. This is where I get afraid. And so I think if you can build those relationships, and what Tim's talking about is this patient who gets moved around from doctor to doctor to doctor, and everyone sort of says, go to somebody else. And it's very frustrating for the patient. And I think sometimes as physicians, then it becomes our charge to help them, guide them to the right person who can help them. I mean, nowadays, modern migraine medications, even including Botox to the forehead, is tremendous at relieving this. And the last International Headache Symposia consensus statement actually says this kind of the 4 quadrants we deal with, the 2 forehead and the 2 maxillary, is like the 3rd or 4th common atypical migraine pattern. So we're all going to see it a lot. I think all of us are nodding because we all see it a lot. And this is a case where there is a pathology that we worry about, and sometimes then it can kind of lead us into a dangerous situation where we really want to help the person. And sometimes the hardest thing to do is to tell them no. I think it's very hard for me. And so this is where partnerships can help you, getting colleagues who, more than just Cymbalta. I mean, Cymbalta is one medication. There's so many migraine medications now that might help them, may help in this kind of difficult scenario.
I agree totally. Actually, the neurologist I sent him to is a friend of mine, and he's a headache expert in Athens. So he actually agreed that we do something, and so I got his suggestion for that before I did. Anyway, we'll see with time.
Tim, since I met Nick Jones, I'm very carefully with pain. Thanks very much.
Sorry, I missed that. I didn't hear you, Andreas. I didn't hear you, sorry.
No, I said, since I met Nick Jones, I'm very, very conservative when I have a case like this. I start thinking and then, but
Thanks
it's a
the
good
comments.
case.
It's
Thanks very much.
Very useful for everybody.
Excellent presentation. Thanks
Absolutely.
very much.
Sorry, can I have just a small question to you, Tim? Why do you think the pain went away after the operation? From your point of view.
Sorry, why?
Why the patient was so good after the operation, no pain anymore? What's your...
Why he wanted to have the operation?
No, after the operation you said there was no pain anymore.
Yes.
So why do you think that happens after your operation?
Well, this is a very difficult question. Why did he have the pain in the first place? I mean, can we have an answer for that? Yes, I'm right. You're right. I mean, I agree, and thank you for the comments. And we all learn in the process. This is a case sent by Phillipe, a 40-year-old man, history of rhinosinusitis, who presented with this frontal swelling. Sorry? Oh, we have a question from the floor. Yes. Must be a button on the... No. Yeah. Okay, you may have a point on that. Yes?
Neuropsychology of a surgical process, cognitive dissonance.
I agree, but we were talking about a very severe pain which did not respond to any medicines. Anyway, this is a case by Phillipe, Eloy, 40-year-old, history of rhinosinusitis, presented with this frontal swelling, which is obvious on the pictures. Clinical examination, no pus in middle meatus. Responded well to antibiotics and steroids with some clinical improvement, but then the swelling recurred. CT scan, this one, and we can see this erosion of the anterior wall of the frontal sinus, some sort of involvement or maybe erosion on the posterior bed, some swelling in the soft tissues. Phillipe, you want to comment at this stage?
At the beginning, we thought about an infectious process, and because there is resolution after antibiotics, but then we have relapse. And so here there is no pathology in the pathway of the frontal sinus. There is no ethmoiditis, so there is no, of course, infectious disease. And we can see that there is hypertrophy of the mucosa and maybe osteomyelitis on the anterior wall and posterior wall of the frontal. And yeah.
Yes, Jannis?
Also, there are basic principles. If this pathology will not improve after 1, 2, 3 antibiotic therapies, then I have made the experience, I like to have a biopsy.
And an
It's
MRI.
clear. An MRI before, of course, to see what is the situation with the frontal brain. I have operated one a patient with cancer in the frontal sinus, a lady from Ukraine, maybe Chernobyl, etc. I didn't know why. This was the only and my last case. And I saw also a sarcoma, 2 sarcomas of the frontal sinus, 2, 3 lymphomas. So if there is no improvement, so we need a biopsy.
That's what we did. We didn't do an endonasal surgery. We did a biopsy just on the frontal, and the diagnosis was a diffuse B-cell lymphoma.
Yes, Andreas?
Tim, did you make an MRI?
Phillipe?
At that time, I didn't. I made further biopsy, and we had the diagnosis with the biopsy.
Okay.
And such a differential diagnosis can be also histiocytosis, Langerhans histiocytosis, especially also in children or in young. Yes, exactly.
So, you did a therapeutic a biopsy through a white trephine, and this is the histology, and the diagnosis was B-cell lymphoma. Patient had chemotherapy, did well, 3 years after treatment, he is fine.
Tim, the other thing that scan can look like, it can actually look like interosseous meningioma as well. Interosseous meningioma can have that little reticulated pattern, and they can get some intermittent swelling when it gets to the frontal table. Like the periosteum seems to react, and you get that little bit of swelling and settles down. I've definitely had those patients sent in with a diagnosis of Pott's puffy tumor, drain their sinus. And they all have mucosal inflammation. That's what gets confusing, right? They all have that little bit of mucosal inflammation that tips us off.
Right, similar case of mine, 58-year-old man, again with some history of rhinitis. The difference here is that the patient presented with acute symptoms, meaning 12 days of painful swelling with local inflammation signs. And pain and local inflammation improved with antibiotics, but swelling persisted. That's the CT scan, and you can see that basically there's anterior ethmoid disease, and the frontal sinus is completely obstructed and full of material, and there is some erosion in the anterior wall, as you see here, possibly 1 point of erosion in the posterior wall. This is the MRI, and you can see that it's a sort of polypoid mucosa which is enhanced in the periphery, and we have this swelling in the soft tissues just in front of that. So we did a biopsy via draft 2A because we had a wide frontal recess, so we didn't want to go through the anterior wall. It was quite easy to remove. Polypoid mucosa, easily detached from the bone. And this was the histology, a B-cell lymphoma again. So patient was staged and treated with chemotherapy. Excellent initial response to treatment. Frontal recess healed nicely, as you see here. But then he came back 6 years later with a relapse and died of his disease. Yes?
Tim, may I ask the panelists, how often do they saw such cases? It's just getting a feeling. I mean, they are really rare, but more important, we have to look very precisely. And the key for the treatment is the diagnosis.
Yeah, absolutely. Well, for some reason, I cannot know why, but for some reason, we do see lymphomas quite a lot in the sinuses. Yes.
But also B cell? I mean, we see quite a lot of NKT T cell, but B cells?
Well, according to the literature known to myself, most of the lymphomas in Europe are supposed to be B cell lymphomas. But I don't have a huge experience in lymphomas, but we do see lymphomas every now and then.
I actually think
they're always B cell.
I think, Tim, these were two excellent cases that demonstrate how important is first to think about and then not to forget the histology. I saw also, you know that here in Greece many doctors remove polyps without histology, and then we see inverted papillomas and tumors and etc. Yeah. And I think these two cases really demonstrate the histology and first to think and to think about the worst for our patients.
As you see on the slide here, a Pott's puffy tumor is not a very common diagnosis. So in every case, we have some swelling with bone erosion, frontal swelling. We must exclude malignancy before we call it a Pott's puffy tumor. And we need histology for that, so biopsy is mandatory. Yes?
So, Andreas, to answer your question specifically, PIT is part of a multi-center consortium on sinonasal cancer. It includes 7 or 8 now other institutions in the United States where we bank the tumors, and actually our most common lymphoma is large B-cell. But the thing that's unusual about these cases is that they're relatively younger patients. Large B-cell lymphoma has its peak incidence in the 70s and 80s. So it's a little bit unusual, but at least in the United States where, it's just our group of people, B-cells are actually pretty common and of the groups that we see. And unfortunately, large B-cells are not always the best either. These had wonderful results, but some of them are not actually the best of the lymphomas to get. Some of them can be very unresponsive. It may be because of their age too. Older patients maybe not tolerate the chemotherapy as well.
Right. Yes, Philip?
Sorry, just one comment. When you think about tumor, biopsy is not a surgery. So when you take a biopsy, you can do it under general anesthesia, but you take a biopsy, you do not remove the tumor. Sometimes we have patients who are referred because they found an inverted papilloma or a tumor, and they resect the tumor, and you don't know exactly where was the implantation. So biopsy is completely different than the surgery.
Yes, Wytske?
Patients from the
I have just one question.
Yes, please.
Is considering the possible diagnosis also of bone osteomyelitis, chronic osteomyelitis, would anybody in the panel consider the usefulness of employing bone gammography? It could help in having activity of chronic infectious process of the bone.
So I think
it's just a question.
I think a technetium scan would help if you had another history that would lead you towards osteomyelitis. But the downside in malignancies, I think you'll also see bony uptake, right? So you'll see uptake of technetium or the radionucleotide in the bone itself because the bone is actively being broken down by the cells. So while I think it could help you, especially if you had a non-diagnostic biopsy, if let's say you got like a mixed inflammatory infiltrate there, which, and rather than a neoplasm, and you could sort of find some sort of other history to sort of lead you in that way, I think that could absolutely help you.
Right, so we move to the, Wytske, you wanted to say something? No, sorry. This is the next case, 23-year-old man, typical Sumter triad patient with massive polyposis, aspirin intolerance and asthma. 1 year before he presented to us, he had a polypectomy attempted at another hospital, which was abandoned due to excessive hemorrhage, so the patient was not very keen to undergo another surgery. But a few days after that, he presented as an emergency admission with periorbital cellulitis. That's the CT scan and the MRI scan, and you see extensive erosion of the lamina papyraceae and the posterior bed of the frontal sinus there. And here starts the long and winding road of his hard times. He had an operation at that time, which was combined with osteoplastic approach. If you ask me if I did it now, I would not do an osteoplastic approach, of course. But because of the lateral erosions, we thought at that time that we should do it. He did well for a short while, but then he had massive recurrences, which forced us to do another operation very close to the previous one. So up to now, he's had 3 operations. The last one was a draft 3 and revisual full house FES in 2015. And 5 years after that, he had another massive recurrence, asthma exacerbation, and we came to the last visit he came with total obstruction, anosmia, frontal pain, and asthma not well controlled. That's the last scan we did, and you see a massive polyposis image, and you can see the screws from the osteoplastic approach. And how would you treat these patients? Phillipe, you want to comment?
Well, I think that's this case of unstable polyposis, and we need alternative treatment, and we have. So maybe now we think about monoclonal antibodies just to treat. But of course, you have a massive polyposis. And so I think that you have to recommend, in this case, a sandwich therapy. That means that if you have agreement for the reimbursement of this, we start with the biological first, and then we do a surgery with, once more, a complete resection of the polyps. I ask also an MRI just to see if there is mucocele or not. If there is mucocele, your surgery is absolutely necessary. And I don't believe that only the monoclonal antibody will solve the patient now, but preoperatively for 2 or 3 months, then surgery, and then go on for a long period of time.
Okay, Wytske, you want to say something?
Well, I'm absolutely convinced that this will go away by dupilumab, and we now have about 200 patients on dupilumab, and it goes away, just like that. And then, of course, I fully agree with Phillipe, I would do, unless I can see that whole frontal sinus properly, but that will be quite difficult by that narrow remains of a draft 3. I would make a new CT scan to be sure that there is no mucocele somewhere up there. But
Well, it's a draft 3, post-op draft 3.
Yeah, but if there's not much space there, so it can be quite difficult to see totally laterally. But the DUPI will get rid of all the polyps.
But
I'm convinced of that.
I would be very happy to see that the polyposis decrease, but in my experience, even if it's not so large one, when we have such a polyposis, we have hamartoma, rhea in the olfactory cleft, then polyps, and I think that with the Dupixent, for example, there is a partial regression, and so surgery is still necessary.
Yes, Andreas?
Yeah, let's assume the endotyping looks for biologicals, yes, but I'm not sure. I mean, this patient got 3 so-called full house FES operation. I don't know what was done there. And there was 1 osteoblastic approach, the first one.
Well, this was the first operation by
Yes, but this
ago.
could be the source, the reason why maybe he developed a lateral mucocele, and I think the biological wouldn't make sense to treat this. And I mean, he had really significant swelling, redness of his eye, so I would be more interested in what's going on there, and then combining it. So a combination out of maybe surgery to fix this and opening the spaces, because full house FES means you go in and you just take away the polyps, hopefully it's done, reboot, whatever, and then you give dupilumab. But mucocele, very important, not overlooking it.
Vlad?
Yes, from my point of view, even if I don't have much experience with dupilumab, I think this will be the first step. And after treatment, as far as I saw, I read, and for the moment I told them I don't have much experience, but I'll do like this, the biologic treatment, and then a new CT and see exactly if we need more, a new operation to be done.
Jannis?
Yes, this is,
Agree.
this is clear. I would like to say not to forget the obliteration. Rarely, we use it rarely, but if you have such a case with a massive neosteogenesis, then this is also a solution. Not,
Yes, but
not
not on this
very
case.
rare, not for this case, but I think we should say that there is also another kind of surgery that can help us in cases with a very strong neosteogenesis of the frontal sinus.
Okay, so this was our first patient on dupilumab. Started in October last year. He had a very impressive course, and you can see the pictures. Left picture is when we started the treatment. The picture in the middle is 2 months later, and the picture on the right is 4 months later, and you can see polyp score, SNOT 22, sniffing sticks, total IgE went down also, eosinophils also. Asthma is not completely controlled, but it's okay now. And I'm saying this because the patient had an uncontrolled asthma. And maybe he's our only patient on biologic with uncontrolled asthma. Most patients have mild asthma. But Wytske, you wanted to say something?
Interesting,
Andreas.
this NOT 22 was not very high in this score.
Sorry?
The
Yes, it
yeah?
wasn't. Yes,
Yeah,
surprisingly.
Yeah. And did you see a mucocele or not? Was no mucocele in this patient?
Sorry?
A mucocele.
Mucocil, no.
Okay,
there
so-
was no
okay.
mucocil. You can see the draft 3 on the right side, which is wide open, and there's no sign of mucocil anywhere.
We will be very happy just to prescribe, to be able to prescribe this biological for the future. But up to now in Belgium, for example, we can't prescribe as an ENT such a medication. We must
Right.
ask to the pneumologist, and if the asthma is uncontrolled.
Yeah.
So up till now, even if the dupilumab will be proposed for an ENT indication and a prescription by an ENT, until now, we can't prescribe it because
Right.
we have no reimbursement.
Actually, in August 2020, the drug got approval from the EMA for polyps, and we can.
2019. December,
19 was
yeah,
it? Was it?
November
All right.
2019. Yeah.
I thought it was 2020. And we can, in Greece, we can prescribe it through a very complicated bureaucratic procedure, but we can. And now we have, yes, now we have 16 patients on dupilumab, doing very well, all of them. And we're following the course very closely, and hopefully we'll be able to publish it shortly.
Can I make one comment? Because I was really intrigued when you showed the CT scan, and of course it was only a few slides, but the impression made from that was that actually the opening of the draft 3 was quite obstructed with,
Yes, it
with
was
bone.
just a point, but you could see
But
on the
further
picture.
down it was excellent.
The picture was
Yeah,
wide open.
yeah, marvelous,
So
yeah.
maybe it wasn't the right slide I selected, but I just wanted to show that everything was full of polyps. So just a quick note on therapeutic options in recalcitrant eosinophilic CRS, which is not the subject of this table, of course. But do you think that minimal surgery has a place in the treatment of these patients? Or you agree that radical surgery followed by topical steroids is the first step after the initial medical treatment, of course? You want to comment on that?
You know, I think it totally depends on your local situation. At the moment, EPOS still advises to do surgery before biological, and I still feel that that's the way we should proceed because it's so terribly expensive.
Yeah.
And we know a lot of patients will do well. On the other hand, you could argue that if you know already that a patient has all the signs of having very severe recalcitrant disease, and you know that there is now medication that is so effective, and we start now to learn to play with it and how to taper the dose, because it's 15,000 euro per year for the first 6 months. But we now have quite a good experience in reducing the dose to once every 4 weeks after half a year, and then once every 6 weeks after a year. And now, well, that's the experience we have now. So
Absolutely.
we now start with the first every 8 weeks. So then the price becomes totally different. If we can come up with patients that we give 4 shots a year, for example, then it's 2,500 euro, and that's much easier to explain to our health payers. So I think we have to learn in the coming years how, like we learned to play with systemic steroids, how we are going to, I know in the US quite a lot of people use it as sort of one shot, if patients, I heard from some colleagues saying, they give it just like a boost of systemic steroids, now just 1 or 2 shots of, is that true?
The short answer is yes, that's
Okay.
true. But you know, I mean, I do think you get transient improvement. But you can see even by this particular patient, you know, the polyp score keeps getting better with more therapy, right? So I don't know. I love the idea of modulating the immune response so that we can taper these people to less and less. Because every 2 weeks, it is a significant expenditure. Yeah. But if you can get it to a reasonable number every 2 months or every 3 months, I mean, That's actually very reasonable, especially in these very young people who, you know, I mean, look at this 23-year-old in the subsequent, I don't know, 10 years that Tim pointed out. I mean, that's a lot of surgeries and a lot of suffering. And sadly, unfortunately, his asthma, which is probably his greatest risk of long-term health debilitation, is still not controlled. No. You know?
Sorry, Andreas wants to say something. Sorry, Jannis, you're the next.
Yes. I would like only to add that for the biologics, two are the most important questions for me. The first question is, who is the right patient to optimize therapy, to reduce failures, and to optimize costs? And the second is the timing. And we cannot answer, I think, this question. We need further studies to see what timing is the best for our patients, because this is an expensive therapy. So
Yeah,
we
absolutely.
should know.
On the other hand, we are very happy because now we have an option more. Because we do, all of us have patients. We've done everything to them, several surgeries and drugs and topical steroids and whatever, and they still have problems. Sometimes these problems are not reflected on the snot, as Andreas said, and you're right about that, but snot is a general instrument for quality of life which does not always reflect the symptom score. So it's, for example, most of the patients, the main problem is anosmia, which is just one number on the SNOT 22. So it's not, we record it, of course, but it's not the only thing. You want to say something, Andreas?
Yes, let's come back to your point, and I love all the points, and for the audience, I mean, I have always problem. No, go back one.
The previous?
Yeah, the previous one with the listed points. No.
The next.
Go.
The history. The next, sorry. I can't hear you very well, you know, because you're facing the audience.
I'm sorry.
So, yeah.
Okay, one more.
This one?
One more.
One more.
One more. Okay. I always have problems with the term radical surgery. I don't know what's radical surgery. Systemic steroids, we want to avoid as much as possible. Long term is bad. Revision, radical surgery, reboot. I discussed with Klaus Bachert this morning in a session. I said, Klaus, I said to you, 2018, you come to Munich, but you show me 3 video clips where I see how you do reboot. I don't know how to. Maybe we are closer than we think, but I have to see how he's doing reboot. I'm not really understanding reboot. Biologicals, cost, big problem, criteria for patient selection, biomarkers. Do we have new things how to handle the patients? Monitoring of results, very important outcome. That's why we do surgery, treatment. And which biologic for which patient, we don't know. We will see. Studies will see it.
Well, I showed this morning, there is a systematic review and a meta-analysis published last week in JCI, so I don't, I just, because I had to give the talk, found it, showing dupilumab to be superior to the other one. So it more or less proves what we all felt already. Yeah.
I would like just to make a comment about the definition of recalcitrant eosinophilic ERS. When you have a patient who comes to you because he had a lot of surgery and it doesn't work, it's not necessarily because the surgery was not correctly done, but maybe because the diagnosis is not right. So is there allergy? Do you have treatment? For the treatment, do you use the treatment recommended by the international guideline? Is the patient adherent to your treatment? And does he follow your treatment as long as you think? And then you have some cases which are the severe disease, chronic disease. So we have some cases with unstable evolution and dramatic evolution, and for this, we need the biologicals.
Absolutely agree. So we go on to the next case. Patient, 70-year-old male, referred for frontal sinusitis. The interesting thing is that the referring physician reported 3 episodes of meningoencephalitis during the last 45 days, which can't be true, of course. Must be one not well treated, obviously. Only symptom headache. Patient had fatigue, no temperature, no nasal symptoms. And the important thing in history was cancer of the lung, for which he completed chemotherapy 1 year ago. And it's supposed to be, according to the oncologist, well controlled at this stage. He had also chronic renal failure on regular dialysis. So this is the endoscopy, and you see this polypoid mass in the olfactory cleft and the just in front of the middle turbinate. This is the CT scan, left frontal sinus obstructed with some signs of erosion, maybe in the posterior wall here. Frontal recess obstructed, sinus obstructed. That's the MRI. Polypoid masses, obstructed sinus. So how would you deal with this case? Yanni, you want to say a few words?
As I said, basic principles, take a biopsy. It can be a metastatic tumor. Maybe because you demonstrate that he has lung cancer before, so maybe this is a metastasis. We see it rarely, but
right.
It's possible.
Okay.
And I would always be worried about the bony erosion on the posterior table of the front side. So this looks like something you have to think very carefully.
Okay.
Don't you think that's a partial volume effect? I don't see a bony erosion. Well, you should
So I can't hear you, Wytske?
need the full set, but I don't think so.
Anybody else want to comment? Biopsy, yes. So we did a biopsy by a draft 2 procedure. That's the draft 2. That's the opening to the other sinus as well, just in case. Polyps, anterior ethmoids, olfactory cleft. Everything was okay. Discharged home in 2 days. Histology, inflammatory polyps. Disappointment. And then 10 days later, another meningitis. Emergency admission elsewhere. He did an MRI, brain and whole spine, which showed multiple foci of neoplastic leptomeningeal deposits in lumbar and cervical spine. So it was neoplastic meningitis, which we don't see very often, do we? So uncommon metastasis in late phases of cancer, non-specific symptoms, of course, bad prognosis, limited evidence on what to do, mainly experts' opinion. The message here is we should suspect it in history of neoplasia.
Tim,
You want to comment?
neoplastic meningitis. What was the histology of the neoplasm?
The
histology, the biopsy result.
Well, the biopsy was just.
Was it an extra nasal?
The symptoms, the result was that what we removed had nothing to do with the patient's problem. The patient had neoplastic meningitis, and this was just a inflammatory obstruction of the because of this polypoid mass of the frontal sinus. But
it's not. But this is not a clear answer. This is not a clear answer. So we have to check the patient. Maybe a CT scan and etc.
Well, he did everything, of course, but the result or the conclusion was neoplastic meningitis, and this explains the history, which to me was very strange. multiple episodes of meningoencephalitis doesn't make any sense, does it? Of course. So, another thing to discuss is how do you deal with postoperative frontal obstruction? So, two examples. This is a lady, no asthma, had an operation, did well, intranasal steroids, washouts, budesonide washouts, everything okay, but 6 months later, she came back with obstructed sinus on the left side, with some signs of neosteogenesis, if you see, when you see here. This is a man, 39, similar case, an operation. You can see that it was, well, radical enough to my experience, and we did postoperatively budesonide washouts, as we do in most patients, polyp patients, and came back 1 year after the operation with obstructed right sinus. So these are the cases. How would you treat these patients? Revision operation, conservative, if operation, which approach, selection criteria, balloon, again. I don't do balloon, don't look at me like this, Andreas. I just like to ask about balloons, I don't do it. Anyway, and steroid stents maybe? Steroid-eluting stents could be an option. What do you think? Andreas, you want to start?
That's a lovely case, this, I think. I mean, case 8A looks to be a little bit osteoneogenesis when you want to open it, so I think you have to open it. And in this case, maybe drug-eluting stent would help. I have a series of this, and they are quite good in this case. So once again, it depends on the local situation, but this is an option you should keep in mind. And the other side looks not too bad, very wide anterior posterior diameter, and maybe the problem is not up to the frontal. I'm not sure. There seems to be. I'm not sure if there's a tiny lamella very high up in the front. I'm not sure about this, but I think the blockage is in the ethmoid cavity. Maybe you go there. Maybe it's a incomplete resected concha bullosa, and you open this nicely, and then, you know, some secretion will come out. So this could be.
Okay. Vlad?
Maybe it might be some thickening of the mucosa in the frontal recess. So this is why I'm thinking a surgical procedure will do good in the beginning, and the stent-eluting corticosteroids will be very nice to put there. Maybe this will be the solution. So small surgery and then steroids on inside.
Jannis?
I will try it conservatively in the beginning, and if the result is not good, then I will open it and see what is the problem, what is the reason for the obstructions. I cannot tell that. I cannot see in the CT now which is the reason for the obstruction. Yeah. I think we have to see maybe a scarring, maybe a circumferential traumatization of the mucosa. You know,
actually,
we have to see.
On the right side, the gentleman, 8B case, had just polypoid mucosa in the frontal recess, which we topically removed during follow-up, but it kept recurring all the time. So just polyps there for some reason. Wide frontal recess, as you see. On the other, the lady had a narrow recess with neosteogenesis, as you said, Andreas. So, Wytske, what do you think?
Well, I agree with Jannis, but especially the 8B case, I would also do new pathology, because if it is such a difference into the healing on both sides. It wouldn't be the first time that you find an inverted papilloma in a patient who had normal polyps in the beginning. So if there's such a big discrepancy and it is really polyps coming back all the time, I would send it to the pathologist again and again and again until they tell me it's an IP. The A case, of course, is easier, and I fully agree with what Andreas said about it.
Okay, Phillipe?
Well, I think that for the 8B, maybe I try medical treatment and it doesn't work. I do revisionist poidectomy. I send all the mucosa to the pathologist because, of course, if you have unilateral recurrence, maybe IP is behind. I never use balloon and steroid-eluting stents. And for the 8A, once more, I tried just to do a surgery limited to the frontal recess. Maybe draft 2B, but not at the first time draft 3, because once more, if there is no pathology on the right side, on the opposite side, well, I try to preserve it.
Okay, Andreas.
Tim, a short comment. I mean, when I make my patient selection, my indication, I base it on 3 columns. First is, of course, the history. Second, I look in the nose, a simple endoscopic finding, 0 degree, nice endoscope, and then I make a CT scan or MRI, and this is, the next step then to decide what to go on. And I agree with Wytske. If there's any suspicion for inverted papilloma, something strange, yes, but it can be a very simple scarring. You open and yet...
Yes. So, sorry, let me go back. A little detail which makes difference is that the lady on the left works at the hospital I work in. The gentleman on the right lives far from Athens. So this is very significant to my practice because this lady I could see every day if I wanted, but the gentleman on the right I could not. So on the right side, I would choose an approach, a method, which will give me the ability to to program the follow-up visits a bit far apart. But on the left side, I didn't have a problem like this. So I thought that I could be more conservative on the lady, because I could inspect the area every day if I wanted, but the gentleman on the right must have something more than that because I couldn't see him very often. So what I did it 2A on the lady, and we had some neosteogenesis as you see. I removed it there, and I chose to do a draft 3 on the gentleman. This is the post-operative image. We had large frontal sinus, large wide frontal recess, and so this is the procedures I chose.
I'm afraid we have to stop.
Sorry?
We have to stop.
Finito.
Fine. Oh, sorry. Yes. So thank you very much. Mr. President, you want to? No, I mean the president of the session.
Thank you all for your attention. I think there was a wonderful diversity of ideas, and I hope that you got a wonderful experience here. Thank you again for attending.
All right. Thanks very much.